Good evening, and thank you for joining us. I'm Dr. Linda Scott, Dean of the University of Wisconsin-Madison School of Nursing. I am pleased to welcome you to the 2020 Littlefield Leadership Lecture. As in years past, tonight's Littlefield audience of approximately 600 individuals represent a breadth of professions, perspectives, and life experiences. This is a reflection of our partnership with so many of you, both within and outside of healthcare. The Littlefield Lecture remains an annual tradition that allows us to reunite with colleagues and forge new connections with others. Tonight, we missed the chance to make such connections and reconnections in person at Cooper Hall. However, there is an upside to this. Hosting a virtual Littlefield Lecture removes the barriers of distance and travel. We are joined by so many of you who otherwise could not have attended. We have enjoyed hearing from some of you who are happy to be with us from afar. Not only do we have attendees from all parts of the United States, but our audience extends to multiple continents. No matter where you are connecting from, I appreciate that you have chosen to be with us this evening. Before we begin the program, I would like to thank the Friends of Littlefield, who conceived and have continued to support this annual lecture series to honor Dr. Vivian Littlefield and her service to the School of Nursing. The Friends' vision of a lecture series to highlight nurse leadership set the course for this tradition. Thank you, Friends of Littlefield, for this gift you have given to our school. I would also like to thank members of our Board of Visitors for their support of School of Nursing initiatives and for the guidance and insight they provide through their service. And now, I would like to share a few words about our guest of honor, Dr. Vivian Littlefield, Emerita Dean of the UW-Madison School of Nursing. It was her leadership that inspired this lecture series, which bears her name. Dr. Littlefield is joining us this evening from her home in Colorado. Many of you knew her as a dean, professor, colleague, or as a mentor during your time at the School of Nursing. For those of you who do not know about her, I'd like to highlight Vivian's legacy and impact on the profession and our school. Vivian Littlefield served as dean from 1984 to 1999. She's a recognized expert in women's health, nursing care delivery, and the impact of alternative approaches to care on patient outcomes. She also served as National Chair of Nursing for the American Red Cross. Vivian is a member of the American Nurses Association and Sigma Theta Tau, and is a fellow of the American Academy of Nursing. Her legacy in the profession includes her dedication to mentorship for countless nursing students and nurse researchers. She is a passionate advocate for nursing leadership. In addition to Vivian's legacy of leadership as dean, she envisioned nursing education and research as its own academic unit. Through her advocacy, Sidney Scott Cooper Hall became a reality and a home for the School of Nursing. Emerita Dean Littlefield, thank you for your leadership and impact on the School of Nursing and your contributions to the profession. I am so glad that you have joined us this evening. Now, before I introduce our speakers, I would like to make one final acknowledgement to recognize that our physical campus of UW-Madison on the shore of Lake Mendota is Ho-Chunk land. Today, we respect the history, culture, and inherent sovereignty of the Ho-Chunk Nation and the 11 other members of the First Nations of Wisconsin, and we value their continued presence. I offer this statement about the land and our history out of respect for all Indigenous people of the past and present, and as an expression that our commitment to learning on this land includes the pursuit and acknowledgement of truth. And now, it is my pleasure to introduce our 2020 Littlefield Leadership Lecture presenters, Dr. Barb Bowers and Dr. Robyn Stone. Both are experts whose careers have made tremendous impact on policy and life-changing contributions to the health and well-being of older adults and caregivers. Dr. Barb Bowers is the Associate Dean for Research and Sponsored Programs and the Charlotte Jane and Ralph J. Rutherford Chair at the UW-Madison School of Nursing. She is also the founding director of the Center for Aging Research and Education, fondly known as CARE, at the school. Dr. Bowers' research focuses on frail, older adults and people with lifelong disabilities in both communities and residential settings. She is interested in how public policies, organizational practices, and models of care delivery influence quality of care and quality of work life for caregivers. Her interest in work and life quality for employees in long-term care has led her to examine and explore staff turnover and improving staff development. Dr. Bowers' work with informal caregivers at home has led to the development of tools to provide anticipatory guidance and support for caregiver decision-making. In 2018, she was inducted into Sigma Theta Tau's International Nurse Researcher Hall of Fame. Dr. Robyn Stone is the Senior Vice President for Research at Leading Age and co-director of the Leading Age Long-Term Services and Support Center at UMass Boston. She is an experienced researcher and policymaker in long-term care and aging services. Dr. Stone has developed and managed studies to identify best practices in aging services delivery, evaluation of program processes and implementation, and assessment of outcomes for consumers, staff, and organizations. Dr. Stone has spearheaded the center's major applied research initiatives. And as a member of several high-impact legislative committees and professional organizations, she serves as a bridge between research, policy, and practice communities at all levels. Dr. Stone worked in policy development for older adults and people with disabilities as a U.S. presidential appointee, serving as Deputy Assistant Secretary of Planning and as Assistant Secretary for Aging. I am delighted that both Dr. Bowers and Dr. Stone, Barb and Robyn, as they are preferred to be called this evening, will present the 2020 Littlefield Lecture and an armchair discussion. In addition to being colleagues, Barb and Robyn are dear friends. They met while in graduate school and have found that their professional paths not only continued to cross, but that their careers became intertwined. They have collaborated on multiple research projects and, along with their teams, developed and implemented numerous initiatives to improve the work life of direct care workers and the quality of care that they are able to provide. Over the next 30 minutes, Barb and Robyn will have a dialogue on some of the most pressing issues we face in supporting and caring for older adults. They will walk through the history, evolution, and current situation in the United States, including some of the greatest challenges encountered in providing quality of care to this population. Following their conversation, I will rejoin them on screen to convey some of your questions that we have received. And also, please feel free to submit additional questions through the chat feature. I am now to invite Barb Bowers and Robyn Stone to begin their conversation. Welcome.
Welcome.
Thank you.
Thank you. Hi, Barb.
Hello, Robyn. It's
Hi,
always
Dean.
to talk about this. So, topic we talk about all the time. Yeah, great.
Yeah, we've been planning this for a couple of months now, and this is an unusual lecture, I think, for both of us. Because of COVID-19, we actually decided that we would try to have an informal conversation between the two of us. As Dean Scott said, we actually met about 40 years ago at UCSF and UC Berkeley. Both of us were out in the Bay Area, and our careers have intertwined ever since. So one of the areas that we have focused on quite a bit over the years has been family caregiving. And I wanted to start with you, Barb. Give us a sense of what you think has changed over time and and what really has pretty much stayed the same?
Oh, great question. In terms of family caregiving, there's a lot that's actually stayed the same. We've always taken care of older families, older members of our family. I mean, that's nothing new. Been going on since the beginning of time. The other thing that's not new is it's usually adult children. And I think nobody will be surprised that that's mostly women, daughters-in-law who have taken the lead on that. That's always been the case, and it will continue to be the case, I'm sure, at least for the foreseeable future. There's something else I think that people don't think about a lot unless you've been in this situation, something that has also not changed. And that is that when we think about family caregivers, we usually think, well, they take care of somebody in the home. And then when their older person is admitted to a nursing home or assisted living setting, that they have handed off the care to a group of paid professionals. And in fact, that's absolutely not true. I worked on a dissertation in the 1980s, and one of the things that I saw was that families just kind of moved their caregiving into nursing homes. And that's certainly the case now in assisted living. There are places that, because of challenges with staffing, actually count on family members to provide some of the care. They know they're going to be there to help at meals. And so they are kind of counted in as part of the staff. And I know people who have family members in assisted living, as the family member declines, what often happens is more and more caregiving comes from other family members. Something else that hasn't changed is that caregivers don't see themselves as caregivers. It's actually really hard to reach out to this group of people to provide services or let them know about supports because they don't see themselves as caregivers. So they don't even respond to something like that. They see themselves as the wife, the daughter, the husband. And that's what you do. You just, when a family member needs help, you provide it. So they don't actually see themselves as caregivers. That's actually a bit of a challenge. I think there's also some really important things that have changed. Availability of people to provide care. This is on a demographic level. We have seen what's called the old age dependency curve ratio really shift over the last decade or two. What this means is that if you take the number of people, or the percentage of people in the population who are between 18 and 64, and compare them to the number who are 65 and above, that ratio has been shifting pretty dramatically and has almost doubled the number of older people compared to those in working age over the last 20 years. That has really profound implications for availability of family caregivers as well as availability for paid workers. Something else that's changed that's pretty important is the kind of caregiving that people are expected to do now. AARP did an interesting study where they were looking at what do caregivers do after someone's discharged from the hospital. And they found the level of technical skills required for the caregiving was incredible. It's the sort of things that we used to have home health nurses do. So they have developed a series of videos to help. And the last thing I think that's changed that's really important is the recognition of the magnitude, the intensity, and the impact of caregiving in this country. We have, I can remember not that long ago, there would be elected officials who would stand up and say, if only people would take care of their family members, we wouldn't have so many problems. They were. It just was kind of invisible, partly because people didn't call themselves caregivers. Mm-hmm. I think there's general recognition now, and there have been like 100 pieces of legislation introduced in the last 10 years. Not many of them passed, but they're all recognition of caregiver supports that are needed. So I think those are probably the most important things. And one other thing about recognition is employers are starting to recognize the magnitude of caregiving of their employees and the impact it has on productivity. And there have been studies looking at the lost productivity. It's huge. We have people retiring early, taking sick days, taking vacation days, going part-time. And that has a huge impact. And also presenteeism, kind of being there, but not really being there. Yeah. So important policy. Robyn, I want to follow up on policies and ask you a question.
Sure.
You've had some really interesting federal level policy positions, as well as now directing the national research arm of Leading Age, National Association for Providers. So you've had a great national and international view. What do you see as the most significant changes that we've seen, good or bad?
You started by talking about caregiving, which, by the way, was my original work in the late 70s and early 80s. I did one of the first national studies of family caregivers in the United States. And I was talking to Barb offline a couple of weeks ago that I worked on the Hill for, I had a little stint with Olympia Snowe when she was actually, before she was a senator, when she was still a congressman in Maine, and wrote an issue brief for the Congress called Exploding the Myths, Caregiving in America. And it actually was one of the first times that policymakers were actually paying attention to caregivers. We had a whole series of researchers who had been looking at caregiving even in the 1970s, certainly Bernice Newgarden, Ethel Shanis, and a few others really were sort of the grandmothers of that research, but really policy people were not paying attention. I think we have come a long way in the area of family caregiving in terms of policymakers paying attention. And certainly we have, as Barb said, a lot of legislation. What I will say is a lot of that activity has still not been followed up by a lot of investment in terms of dollars, resources, as we see in some other countries. So we really have not, at either at the national or the state level, seen the kind of action that we see in some other countries around actually paying families. Although we do have now Medicaid programs that actually pay families as family caregivers. The Family and Medical Leave Act, which passed in the early 90s, provided unpaid leave for family members who are providing elder care as well as assistance to younger people. And now we're beginning to see some states that actually have paid family leave. And I think that's a trend that we're going to continue to see. A couple of the other trends that I think I've seen in the research that we have done, and certainly in the change in terms of the continuum of care, is a tremendous shift from institutional to home and community-based services, really starting in the early 80s in Oregon with the first real strong waiver program that actually shifted dollars from institutional care to home and community-based services for the Medicaid population. And so we have seen an ongoing shift in the amount of resources, public dollars, particularly through the Medicaid program, that is going into home and community-based services. The new scorecard that just came out from AARP last week shows an even more, an increase, a continuing shift to home and community-based services, which, by the way, includes not only care in the home, but care in other residential settings, such as assisted living. So that is another trend that I think we have seen and will continue to see over time. And I think one of the questions around COVID-19 is how much of the fear of nursing home and congregate settings is actually going to move even more of the demand into home and in other residential environments. And do we have actually the resources for affordable options for people? So to me, that is an outstanding question. We've seen shifts in the Medicare program. We have growth in Medicare Advantage, managed care plans, which has both its good points and its bad points. I think one of the things that's going to be interesting to look at is how much the supplemental benefits that are now available through Medicare Advantage actually are taken up by the plans and then made available to people taking Medicare beyond its historical acute and primary care focus to looking at some of the social determinants of health, paying for personal care, paying for transportation, the kinds of things that people need to actually live and thrive in the community. So I think the shift towards managed care, value-based payments is something that I have also seen. A continuing interest in integrating acute, primary, and long-term services and supports for older people as well as younger people with disabilities. I will say, however, that a lot of that continues to be rhetorical rather than reality. There's a lot of a focus on the financing side of integration and care coordination, not as much on how delivery actually is achieved. And then my pet issue happens to be, do we have a workforce that actually understands how we're going to achieve that? So there have been a lot of policy changes. We have a lot more to go. Years ago, we had a lot of focus on trying to find a universal coverage model for long-term services and supports. We've had a number of attempts at that starting in 1989. And here in 2020, we still do not have any type of universal financing for long-term services and supports. Although I can say that at least 6 states now, one state has a program, Washington State, and a number of states are exploring options for financing long-term services and supports through state vehicles.
Yeah, there have been a few attempts at a federal level.
Yeah.
And I hear, I don't know the details, but I hear Biden has long-term care in his plan. So we'll see what happens.
Yeah.
Take this a little further. I want to ask you, you've seen, again, in this country and other countries, the systems, the services, how they're organized, what's available. What do you think we do really well? What's missing or broken? And where would you like to see us go?
You know, it's interesting. A lot of times people think that we are not as far along as other countries in the area of care coordination and home and community-based services. But actually, over the years, because I've had now 40 years of actually being able to look at changes over time, we have had many, many people from other countries come to the United States and take a look at our programs and emulate them back in their own countries. Australia, for example, came over to the United States and looked at our consumer-directed models in a number of places, including, by the way, Wisconsin, the old Community Options Program, and took that back and actually then turned it into really a federal program. And they have really pushed the envelope on moving from institutional to home and community-based care in Australia. And a lot of the learnings came from the United States. So what I think we do really well, PACE is another example, Program of All-Inclusive Care for the Elderly, which is a fully managed, capitated program particularly for dual eligibles, those who are eligible for both Medicare and Medicaid, where people who are very frail, nursing home certifiable, receive everything that they need in the community in order to provide the best quality for them and also try to keep them out of higher levels of care, including nursing homes and overuse of hospitals, emergency department use. So PACE is a model that really has been emulated in a number of other countries. So, you know, I think that we do models quite well. I think the challenge in the United States, and partly that is because we are so large and so diverse, is how do we scale models? I've been thinking, for example, in 1998, I was on the advisory board for the American Academy of Home Care Physicians when they were looking at how do they actually begin to bring primary care into the home. And it took many, many years. Through the ACA, we now have the Independence at Home demonstration, in which house calls, typically teams led by physicians or nurse practitioners, but really it's a team-based approach, takes primary care into the home for, high-risk individuals. And, this is a model that is sort of like, a no-brainer in terms of being able to go into the home, assess individuals, see their physical environment, see their social support networks, understand the community resources that are available. But we're just now starting to see that program taken to scale. And I think this is one of the areas in which we have many, many, many demonstration programs. CMMI, for example, the Centers for Medicare Innovation in CMS has focused a lot on demonstrations, but how do we actually take things that work and move them into practice? One of the things that I'm excited about is the change in research with a focus on translation, and much more of an emphasis on what is called pragmatic trials, as opposed to just doing randomized controlled trials, but really looking at what happens in the real world. I think the future of translation and the future of implementation science is really still in its nascent stages in the area of aging services. And I think we have a long way to go, but at least people, organizations like NIA, AHRQ are now looking at the pragmatic aspects of how do we actually translate what we know into real world practice and also bringing it back into better policy.
Right, you're right. A lot of the federal organizations that support research are really looking at how do we make this move into the real world quickly.
Yeah, and
both a huge lag in time, but also things that never got implemented. Great studies, great demonstrations, and then they just sit there.
Yeah, and I think one of the challenges for us as researchers who also, I mean, both of us really straddle the practice world as well as the policy world is the balancing of robust research methodologies, whether they're quantitative or qualitative, with the need to get things translated practically. One of the advantages of my work over the years, particularly since I've come to Leading Age, which is going over 20 years now, is that I actually sit in the real world. I'm able to see the challenges of providers, staff, consumers who are served, families who are really suffering or are really doing really well, and really trying to understand how do we get research quickly turned around and put into practice. I think is the challenge for all of us, certainly the challenge for the School of Nursing and challenging for the LTSS Center that I co-lead at Leading Age.
Right, quickly, but also things that work. I mean, there is a lot more emphasis on including the end users, the stakeholders who are going to be expected or hope that they're going to use these innovations at some point, including them from the beginning. So these are, as you said, lots of new ways of conducting research.
Yeah, we actually have a new project from PCORI that's looking at how do we engage older adults more effectively in the design of research from the get-go, including, by the way, people who live in nursing homes.
Right.
The notion that just because you live in a nursing home, you actually, even if you have dementia, certain levels of cognitive impairment, does not mean that you cannot be a partner in the research enterprise. And so we are actually doing some work around that. And talking about that, I guess you have been involved in research on models of person-centered care, Barb, for quite a long time, and both of us have certainly been engaged in that. Some of the work we did in Wisconsin a number of years ago, looking at the Wellspring model, for example, and obviously a lot of the work that you've done in researching the greenhouse model, the small house model of both nursing home and assisted living. Can you talk about some of those newer models of long-term care and sort of where we are in the research world? And again, how do we take that into practice and scale?
Yeah. So I think this has been a really exciting transformation in the way we think about care for older adults, residential care. We all have seen the pictures of the wheelchairs lined up in hallways looking very institutional. And this is what nursing homes looked like in the past. I think it was in about the middle of the 1980s when a group of mostly social workers got together, named themselves the Pioneer Movement, and started looking very hard at what are we doing in long-term care settings? What is life like in these settings? What is it like to be a person who's living there? And realizing that the focus was on clinical things, on safety, but almost no attention to real quality of life for people. It was an institutional setting. They had very few choices, certainly didn't feel like home. So nursing home, there's not much of a home part of this. So it's been growing slowly over the last, it's been like 40 years. So it's not new, but it was a slow growth. A lot of early growing pains and people thought this was a little bit odd because the focus should be on giving clinical care. But, when people spend 2 or 3 years there or more, quality of life is a really important issue. So they started with little things like putting white tablecloths on the table, putting a flower in the middle of the table, asking people what time they wanted to get up or maybe what they wanted to eat or who they wanted to sit with in the dining room. Simple choices, but at least started asking people. And it got more and more complicated and more depth in terms of what people were actually being included in terms of choices that they had. And then we got to a point where we were asking things like, so what time would you really like to get up? And what do you want to do in the morning? Well, people might say, It used to be that you'd get the night shift would come in a nursing home and get half the people up because the day shift had too much work to do. They couldn't do it when they came on. So here you are, someone's getting you out of bed at 5 a.m, and you might sit there for 2 hours before breakfast. That was driven by the organization and the tasks that needed to be done. We've moved away from a lot of that, fortunately, and that's all part of this culture change movement, saying people don't want to get up at 5 a.m. and then eat at 8 and just sit there for 3 hours. So we don't do a lot of that anymore. There is still some, but not a lot. As you can imagine, scheduling sort of bumps into preferences. So one of the things that happens is you might have a lot of people now who want to, say, get up at 8 or 9, and then maybe in 3 months from now, you don't have very many people in that category. So you have to start changing your staffing in order to accommodate the choices. And that's where things get kind of tough. But there are a lot of homes that are working on that. I think the other thing that the person-centered care culture change movement really focused on was relationships, building and supporting relationships between the staff and the residents, which staff will tell you. If you ask staff, what are the most important quality of life issues for you? Relationships with staff are really high on the list for most people, as are relationships with family and other residents. But it's relationships, which shouldn't be any surprise to any of us. That's what makes us human. So something that grew out of this movement that's really important is focus on what's called consistent assignment. And all that means is keeping the same staff member taking care of the same resident over a period of time. It used to be we rotated people deliberately to say, we don't want you to get too attached. We want you to be able to take care of anybody on the floor. So you'll be here taking care of this group for 2 weeks, then move you to another group for 2 weeks. And that really interrupted relationships. And there's another part of that connection that's really important in relation to clinical care, which was a nice benefit that came along with this. If you have a close relationship with someone and you're in close contact with them, and you see them in doing a lot of different activities, and you get to know what the sort of little things about them, you will notice changes in condition very early. If you don't see them regularly, you don't know if this is a change or this is the way they always are. And that's one of the most important things we can do in order to prevent real serious clinical problems from occurring, is identify change in condition early, intervene early, and that creates a much better clinical outcome. So in that sense, the person-centered care actually improved clinical outcomes as opposed to sort of being a tension between quality of care and quality of life.
I wanted to say that, some of the work that my team has done on home care has found exactly the same thing. One of the really important findings for home care aides in the home health and home care setting is consistent assignment as well. In fact, it was one of the few variables in the regression analyses that we did that actually predicted intent to quit. In essence, people who have consistent assignment, who are really connected to the same person, are much more likely to stay on the job and get tremendous benefits from it. And a lot of this has to do with the same issue. You get to know the person, you have relationships with that person, you understand very, very nuanced changes in condition. You actually can help address the emotional as well as the personal care needs of the individual. I mean, it seems as though this would be something that everybody would be doing in terms of best practice. And yet oftentimes we see that this is not occurring. And, I think it's one of those research tidbits that we actually have very, very strong quantitative and qualitative evidence of, and yet it's not normative.
Right.
It's not normative in the nursing home. It's not normative in assisted living. It's not normative in home care. We still have a lot of churning and turning of people, and this notion that somehow you don't want aides to get close to the people that they're caring for, which is just antithetical to what is really important in terms of delivering good quality of care and also providing good quality of life.
Well, the other thing that we've seen in research studies is that people often, organizations will say, we do person-centered care, we do consistent assignment. But if you actually look, or you say, how is that different than what you did before? Well, we always did it. So I think there's a real struggle in terms of figuring this out, and a lack of awareness of how many different people, different caregivers touch the same person over a month. It could be 30 or 40 people. Kind of tough when they're providing really intimate care. So something that it's possible to really get that down to like 12 or 14 people when you take all the shifts into account, but it's done in very few places. Let me say a little bit about the greenhouse model. I think most people a lot of people have heard about it. It's not necessarily the best or the only model, although I actually think it's quite good. It's a nice way of, a really effective way of combining good quality of care, good quality of life, and great quality of work life. And I think they've got the staffing issues down and the architectural issues, which is also part of the transformation and culture change in person-centered care, is to feel like a home, to feel like a better place, to look around you and say, this is a nice place to be, instead of it looks like an institution. So the greenhouse model is a national organization, and there are a couple hundred greenhouse homes now around the country, and they're growing all the time. It's a small house, 10 or 12 residents in a house, so it's a more intimate setting. It looks like a house. It looks like your house or my house. It's just a house, regular house. It doesn't look like a nursing home or an institution. They have a small, stable staff. The staff, they say we're like a family. So like a family, if a worker is sick, everybody else fills in. You don't go get someone else's kids when one of yours is sick or gone. They make do with who they have there. And they get to know these residents really well. The residents have their own room, a private bathroom, so they have privacy, feels much more dignified to them. They get to know the staff really well. They have a lot of control over their life. They can get up at 6 in the morning or 11 in the morning if they want to get up then to go out, and they can fix their own breakfast in the kitchen that's available, which is not the case in most institutions. Residents are not allowed in the kitchen. It seems like too many dangers there. People go in, make themselves a sandwich, or ask the direct care worker to get them something. And they cook all the meals in the home. It's amazing what the aromas of cooking food will do to your appetite. So a lot less appetite loss. Families are much more likely to visit and stay longer because it's a pleasant environment. They have to eat dinner with the staff and the residents, and any family members who are there eat a meal together. The workers find this to be a much better quality of work life. There are some issues in terms of they're much more in control of what they do, their staffing. They work out issues among themselves, and one of the biggest challenges they've had is confronting another worker who's not maybe pulling their weight. So that's been a learning curve for some, but it works really well. And I think one of the most effective things that has come out of this, again, is about identifying early conditions, early changes in condition. There was fear in the beginning from a lot of places that, oh, this greenhouse home is really focused on quality of life. The clinical indicators are going to go, they're going to look horrible in this place.
Right.
That's not what they found. The greenhouse homes are all at the top of the quality, low hospitalization rates, because they get things early. And I think it's because the direct care workers do everything. They cook the food, they eat a meal with you, watch how you eat and swallow and whether you're choking. They do activities with you. When you spend all that time with someone and you do rehab during the day, you can see changes. It's like they didn't eat quite as much, and then they weren't quite as engaged in activities, and they went to bed a little earlier. I think something might be wrong, which is a lot quicker identification than waiting until the fourth day you've seen that they weren't eating very well. So it's been I think, and some of these strategies obviously can be used in other places, but it's been, I think, a really successful program. And one of the best parts about it is it does include Medicaid, because I know when we went into this, we said, we're not really wanting to be terribly supportive or help you grow something that's only for people with a lot of money. It can't work for lower income people on Medicaid. We're not so crazy about this program. There are a lot of places that actually have a significant number of Medicaid enrollees in the program. So I think exciting, and we need to do more of that.
Yeah. Well, Barb and Robyn, your conversation has sparked a number of questions, especially around family caregivers or caregiving in general. So I'd like to pose some of those questions to you.
Sure.
Starting with, when you were speaking about the magnitude of caregiving and the need to translate research into the caregiving settings in a more expedient manner, given the increasing burden of care being placed on family caregivers. Can you provide some examples of evidence-based strategies that are most effective in supporting them in general? And then I'm curious if those strategies, one, are different for minority populations or those with less resources, and what recommendations would you make for how to access those services?
Okay.
Well, I could give a couple of examples only because I happen to be on a committee right now for the National Academy of Medicine that's actually looking at one of the latest evidence-based reviews that was done at the University of Minnesota. The HRQ just actually released a report on non-pharmacologic evidence-based practices. Many of you may have heard of REACH2. I can't actually remember exactly what the acronym means, but what it is a multifaceted family caregiver, family partner set of interventions that combines education, support group, a number of different activities and interventions with individual family caregivers and persons living with dementia, in order to support the family caregiver or the partner and actually improve their quality of life and their quality outcomes, as well as the outcomes for persons living with dementia. And it was one of the strongest evidence-based activities, multifactorial activities, to actually be identified as an evidence-based practice. And I think this is an example. REACH2 has had a lot of work done. There have been randomized controlled trials. There have been observational studies. Different parts of REACH2 has actually been examined individually. But I think now the time is right to take an evidence-based practice, which is multifactorial, and to actually put it into practice in various settings, whether it's in an individual home, whether it's for family caregivers and partners who are providing care to people who are living in assisted living or living in nursing homes. This is an example of a very strong evidence-based practice. The materials are all written up. They can be ready to go, but the providers now and the settings in which family caregivers and persons living with dementia are engaged, this program actually needs to be put into practice. The other strong evidence-based practice that we have seen through this AHRQ non-pharmacologic intervention evaluation is a collaborative care model that actually looks at good care coordination between primary care and long-term services and supports for people living with dementia. And that has very strong impact on not only the people living with dementia, but their family caregivers.
Yeah,
these are two examples of strong evidence base, but the providers need to now take it up and put it into practice.
Right, which is a bit of a challenge. And let me just say a little bit about what some of those practices are internally, because there actually haven't been that many evidence-based studies of multi interventions. It's mostly like a single intervention. Does this work? But really, and most of them have shown they might decrease a little bit of depression, but they really haven't made much of a difference, and the impact sort of goes away over time. But to answer the question about what are some of those things that would help and that can be used maybe in low resource communities or work across populations, I think one of the things that I've seen that has been the most consistently associated with a positive impact on caregivers as well as recipients is to help the caregivers understand, in relation to dementia, help the caregivers understand, first of all, that what people call problem behaviors are actually behavioral symptoms. They are symptoms of something. And they are not that the person is being willful or intentional. We still hear this from caregivers that someone with dementia hit them because they were angry, hit them because they're being mean. What they have to understand is they are reacting, they are trying to communicate. And so helping the caregivers understand that there is a reason for this. And the most important thing you can do is try to figure out what the cause is, what triggers the behavior, and to find ways to prevent that, first of all. And there are things we know that work. A calming environment, connecting with a person emotionally. They may not understand verbal interactions, but there's a lot of good evidence that people with dementia can communicate on an emotional level. They can pick up your emotions, the caregiver. They can certainly respond emotionally. And so maybe the communication needs to be more at an emotional level rather than a verbal level. There's certainly good evidence that the quality of the interaction, so not standing over a person or talking to them from another room, but getting to their level, looking them in the eyes, maybe putting a hand on them, so that you're connecting on a much more personal and emotional level. That's calming, that's connecting, and it tends to really calm the person, prevent agitation, and what people, I think, unfortunately, still call problem behaviors.
I will say, Dean Scott, that the work that's been done with people of color and communities of color is way far behind.
Yeah.
And that is one of the major findings that will be coming out in the report that we're going to be producing for the National Academy of Medicine. And that is the lack of a focus on race and ethnicity. A lot of the studies have been actually done with people of middle and upper class whites. And we really, really need a lot more work that really gets to the nuances of how family caregiving and evidence-based practice really works for, a range of cultural, ethnic, and racial groups. So this is a big area that is a huge research gap and a practice gap as well.
And part of that is how we approach people to be involved in research. We haven't done that very well in the past, and that is something that really needs to be improved, to be a collaborator with the community and to give something back rather than just taking something, especially when there's a trust issue, which certainly is for good reason in a lot of minority communities. The other two things that have been found to pretty consistently help caregivers is care management, kind of like Robyn was describing, but also people at home. How do I get through this bureaucracy? What sort of provider do I want? Can I trust this person? And respite. We don't have very good respite programs, not very available, but that's important as well.
Yeah, I want to touch on another area that you mentioned, which is, again, the shift of responsibilities to the home. As we're starting to see more care recipients with higher technical needs, and therefore there's what we often see where there's a medicalization of the home. And so you've talked about care recipients who are older adults and those with dementia, but what are your thoughts about how do we support caregivers who now are taking care of patients who are or relatives who are on dialysis or inotropes? I mean, some of the more sophisticated interventions that we would normally have done in hospitals, and now we're doing it in the home.
Right, and often doing it with no professional support at all.
Yeah. I mean, the CARE Act, which was developed at AARP, and Susan Reinhardt, another colleague of Barb and myself, was very instrumental in this as a nurse herself and a PhD researcher, really recognized the medicalization of the home and the need to have a lot more support, knowledge, and education and inclusion of family caregivers into actual care teams. And a number of states have actually passed CARE Acts where they are now requiring that, for example, hospitals include family caregivers in transitional care from hospital back into the home, and that the caregivers are part of the team, that they get education, that they get support around these medical as well as the social needs. So I think there is increasing attention to the fact that we've got a lot of this activity that's being placed on the shoulders of family caregivers and other partners who don't necessarily have the skill sets and the knowledge to do this. The other, again, are these home-based programs that I am extremely interested in, because the teams that are going into the home really understand the role of the family caregiver and how to actually build their practices around the family as well as the person who is receiving care. It's really a dyadic approach. And I think, these are beginning to be scaled. They are not normative by any means, but I think we are starting to actually move in that direction.
I also think we need to really seriously rethink whether or not it's fair to expect the 85-year-old husband who was a banker or a construction worker to all of a sudden become something that the rest of us think we need a 4-year degree and a license to do. And we've seen people in a project that we had who are terrified about this. And someone says, it's changed my whole relationship with my wife. I don't want to do this. There wasn't a choice.
Yes.
So
there definitely, I think the ethical issues around this, and obviously, this is primarily a female issue because it is mostly on the shoulders of women, whether it's an adult daughter or a wife. And I agree, I think with Barb, that a lot of this has just been taken for granted, that as we move more people out of higher levels of care back into the home, the notion that families can absorb a lot of this without the right training and support, and perhaps, more intervention that is actually clinical from clinicians who know what they're doing is really pretty critical. The notion that you can just allow people to go back home with very high medical acuity is short-sighted. And it has financial implications as well, because it's a way of saving money.
Right.
But the long-term implications of that for the family system is tremendous.
Sure.
Wisconsin has not passed the CARE Act, by the way.
Yeah. There's one other shift for caregivers that we've also seen with the shift in demographics and the number of individuals who are not married, don't have a significant other, don't have children. And oftentimes they're the relationships that they end up establishing with close friends who now end up becoming a caregiver. Any thoughts that you have about that shift or suggestions, resources that those individuals could use?
Boy, I mean, there's all sorts of laws that prevent people and policies, organizational policies, that are difficult for people to get through in terms of being the designated person. So I think one of the things that would happen is, even if you did have a CARE Act, that sometimes they're not seen as the appropriate caregiver or a legitimate caregiver. That's an issue.
On the other hand, I do think that there is an acknowledgement, again, even in the terms that are being used, shifting from a term of family caregiver to care partner.
Yeah.
There is a growing acknowledgement that what I used to call fictive kin in doing research, when it was not a true family member. I think it's growing, and I think the demographics, I mean, I'm one of those folks who is not married and does not have children. I mean, I have an extended family, I have a partner, and I have stepchildren. But the truth of the matter is, not only are we seeing more childless people, we're also seeing more different kinds of configurations of what used to be, the family unit. And again, this is being recognized in terms of both research and practice. The question of how it translates into policy, and I think that Barb is right, going to have to start looking at the nuances of what does that mean for policy, where they become barriers to allowing this to happen.
This is still, there are a lot of places where people who are not blood or legal relatives are kept away, kept out of decision making, especially when the person who is the recipient of care might be seen as somewhat cognitively impaired, then there's sort of no natural progression to go to. No family, so maybe you need a custodian. And so the person who really should be doing it, providing the care, participating in decision-making, who knows that person, is kind of locked out of it. That still certainly does occur. Those are some policies that we really need to change.
Yeah.
Yeah. So, Robyn, you mentioned COVID, and of course, there are several areas of conversation about COVID, beginning with two things. One with the impact on older adults, especially now who are now more isolated, who aren't able to have contact with their loved ones, and that relationship that you talked about earlier is also fractured because of the loss of contact. What are your thoughts about that, and suggestions on how we can intervene?
I mean, I do think we have seen a lot more social isolation, obviously, just by virtue of the fact that we have the social distancing that is required and the lack of visitation, particularly in congregate environments. We certainly have seen that among leading age providers, and our members have been extremely creative in terms of setting up all kinds of alternatives, obviously using different kinds of technology, but also, creating different kinds of spaces, allowing families to visit in virtual ways. But that comes at a price. And one of the things I'm extremely concerned about has been the workforce. And if I didn't underscore that, I want to leave the audience with my main concern that I think is missing, which is that we have not paid an adequate attention to the workforce, from the front line to all clinicians to management and administrative folks across the entire sector, the care sector, and that is something that we need to be addressing. But in COVID, a lot of the burden of keeping people from being socially isolated has fallen on the frontline caregiver. In nursing homes and in assisted living, they're the only people who are allowed to be engaged in the same room with individuals, and so it falls on them, for example, to make sure that the technology connection with a tablet, if they're using tablets, the aide often has to do that work in terms of making that happen. So thinking about the consequences of practice in terms of trying to mitigate some of this social isolation with technology and other kinds of virtual connections, what are the implications, I think, for the labor force here? But more importantly, Dean Scott, I think that COVID has really uncovered this whole issue of how do we deal with social isolation as it gets even more extreme in this kind of COVID. COVID at some point will go away, hopefully. But the social isolation that occurs in nursing home settings, in assisted living, where there is not enough staff and not enough of an environment to actually create the kinds of engagement that is required. And also in the home, the notion that everyone is going to be able to remain in their own home, even if they could. Being in your own home may be the most socially isolating place that you could possibly be in. I think we need to think about that as we talk about aging in place, and really replace that with the concept of aging in community. And that's why I believe very strongly that we need a range of residential alternatives that are well-staffed with high-quality staff who are prepared and understand what to do, who can actually be a complement to family caregivers, and also provide the infrastructure for folks as they age over time and may have different needs.
If I could comment, I think, yes. So we've actually also learned some really nice things, important things from the responses that have been developed by very clever, innovative workers in these settings. I agree with Robyn. This has actually created a burden on frontline workers who sometimes are working with someone who's quite frustrated by a tablet, who's maybe a little frightened of the tablet. So it's not just turning it on and walking away. However, this would be solved if we had sufficient staffing. So to say it won't, it's a problem because it creates more work. And I know Robyn will agree with me. We clearly, for so many different reasons, we clearly need more staff and staff who are given the opportunity to learn more and grow more. We tend to give them a little bit of training, put them in there, and that's kind of the end of it. We've talked to CNAs who say they've been working for 10, 15 years somewhere and have never been to an educational program. We really need to fix that. So, there's some really interesting things that have come out of this. And one of them is you got a tablet, and no one will, I don't think, suggest that we should have all our family visiting through tablets. That clearly misses something. But it has opened up some interesting new possibilities, which is the son who lives in California, who I don't get to see but every 5 years. Maybe that's the only way that you can have a connection to that person. That's something that has been discovered. Like, nobody thought of that before. We could have done it before, but nobody did. I think in a lot of the realms of our life, we've been kind of pushed to do things in a new way that people are now saying, gee, maybe we'll continue to do it this way. People in nursing homes and assisted living have been able to participate in family gatherings and events that they couldn't participate in before through a tablet. And can be much more spontaneous, just to call up anytime you want and have more frequent connections. So that's been something that's actually useful coming out of this. Two other things I want to say about the response to the COVID that's been really useful. One is the connection between the administration, maybe educators in the organization, and staff, particularly night shift staff, who tend to be left out of educational programs, communication in the organization. And because they are not in physical proximity, they started texting everybody with updates, with educational programs. And what they found was that actually, this for the first time, they were connecting the night shift, who now felt more part of the organization, were getting messages that they hadn't gotten before. We've also, I know in a lot of long-term care settings, you see information starts on one shift and it doesn't make it across the shift report or the second shift report. Now they've got a way to do it. So this has been great for education and communication. And the third thing that we've seen a number of places do is a facility, let's say, has 150 residents, and families have a terrible time connecting to administrators and staff trying to get information. Very difficult, can't find them, they're too busy. So a lot of places, in response to COVID and the frantic efforts for families to get information, started these morning Zoom briefings. And what they found is they have hundreds of family members show up for these meetings, ask questions. They usually have like the head of several departments who give updates. The families are thrilled with this in most places. They actually understand what's going on in the organization. They're able to ask questions, get answers. So these are things that probably should have always been done, but weren't. And the last thing that has been really great here is, instead of carting someone off from a nursing home or assisted living to a primary care setting and sitting there, then going to a specialist another time, a number of places have actually pulled these groups together on Zoom. They've got the family members, the older person, the two specialists who have seen the person but not very often, and the primary care provider. Here they are all together in a meeting that wouldn't have been possible in the past. So there actually are some really interesting things that have come out of this. I just hope we continue them.
Yeah.
So you, again, mentioned the workforce a bit and about assisted living. A couple of things. How do we continue the momentum, and so that we don't continue to use the same practice models that we know haven't worked and that we want to improve quality of care? And do you see registered nurses being in assisted living really truly being integrated and a part of the care delivery, rather than the supervisor model that we tend to use now?
Yeah. So, well,
Well, I can, being what I used to call the licensed play nurse, Barb and I know that I actually have a doctorate in public health, so I'm not clinically trained in any discipline. But I will tell you that sometimes I have described some places that I have visited in assisted living as somewhat longer on assistance, on living, and a little shorter on assistance. And I think the challenge that we have in assisted living moving forward, and in any of the residential options that we're providing in the community, is that we need staff who are trained to address clinical as well as quality of life and living environment. And that is a challenge, and I think also an opportunity for us as we develop residential options, whether it's assisted living or a memory care buildings. So I think there is a tremendous role for the RN, and I also think that there's a very strong role for advanced aid positions in assisted living. And so I hope that we will see more and more of an investment in the development of staff in these environments. And as I said, I do believe that for many people, they are not going to be able to remain in their own homes, and either because they shouldn't or because they cannot. And I think we have to have residential options that are well-staffed and with quality folks who are able to address the acuity needs as well as the quality of living needs.
And assisted living is a wonderful way to take care of that loneliness and isolation. I mean,
Absolutely.
you with a community, and you can pick and choose who you want to spend time with because you have a private area. This is an area I feel actually really strongly about. It's hard to make a statement about assisted living because it's like 100 or 1,000 different things. There is no one thing that's assisted living. So it's not a one size fits all. Flexibility is required. I think there are a few things that are really important as sort of core ideas to build from. And that would be, first of all, the way assessments are generally done in assisted living is it's a functional assessment. And that makes some sense because what a functional assessment tells you is what the person cannot do for themselves, what they need assistance with, what they are dependent on. And so that tells you what kind of staff you need, how much staffing you need, how many hours or minutes of care does this person need. We can figure that out in our staffing, or we can deal with that in terms of the charge for the care. That's not an assessment in terms of what a nurse, for example, a nurse or a physician would do. And nurses in particular are prepared to do assessments that answer the following questions. What is the person's condition and what does it put them at risk for? What are the ways that we could prevent bad outcomes here? So how do we prevent the things that might happen that they're at risk for, but that we could at least minimize the occurrence, the likelihood of occurrence? What are the early indicators that something is not going well with that condition or with something else? So it requires the person to understand what are these underlying conditions, what are the things that happen to a person when you add a medication or another condition or a change in their condition. How does that change the whole formula? And now what do I need to look for? And what are the risks? And how do I prevent them? What education is needed of the person, of the family, of the caregiver? So that sort of assessment, first of all, it can't just be done on admission. This is an assessment that is ongoing. So do you need to have a nurse there all the time? Let me answer that question sort of through the back door. I think people need to have access to a nurse when they need one. I'm not saying we don't want to turn these assisted living into nursing homes.
That's the flip side is to, the whole movement of assisted living, particularly the early years in Oregon and other places, were not to emulate the nursing home, but to actually provide alternatives. So I think that's the conundrum, is really how to balance that. But I absolutely agree with Barb that I think there does need to be attention to the clinical and the health needs that are broader. And I also would say that I think there is a lot more that can be done with aides together with a nurse in assisted living.
Right. And that's the next thing I was going to say is that, we're all sort of protecting our turf. The best thing for a nurse who's working in this environment is to have really well-informed, knowledgeable direct care workers, and for the nurse to work with the direct care workers so that they know this person. For this person, you really need to look at this issue. This sign, this clue would tell is something that you would need to tell me about. Catherine Hawes, who's a colleague of both of ours, did a study several years ago in assisted living where they asked the direct care workers, they gave them a list of things that could happen to people, and incontinence, falls, choking, several things. And they asked them to please designate which one of those things could be related to an illness or a health problem, and which ones were just what happens to people when they get old. They checked most of them as just what happens to people when they get old, which tells you that they wouldn't see this as a problem. They would never report it to a nurse. So that would stop the intervention and the identification of a problem right there. Because in assisted living, you don't want nurses to be in there assessing people every day if they don't need it. And so to have accessibility, flexible accessibility of a nurse with a really well-informed direct care worker and a close relationship between those two people is really important. But I think there's one other issue here, and that is what I think are unrealistic expectations of assisted living. You get discharged, say, from an emergency room, and often the providers in the emergency room think they're sending someone back to a kind of hospital-like place. So there is an expectation that care will be provided, that everybody's aware of what's going on. And so I think unless that expectation is made clear about what the nurse is there to do, and that there is someone who's available to do it, that's another thing that contributes to things not going well in assisted living.
Yeah. Well, as our time is coming to an end, I'd like to ask each of you one last question. Given the fact that when it is an election year, and you talked about the importance of legislation, how can we get better funding for the care of our older adults? How can we help communities where long-term care is cost prohibitive? What can we do, especially as you're talking to people in the community, advocates for older adults, future nurses, nurse researchers? What are your final comments and thoughts on that?
For a lot of questions there.
Well, I had to
right.
In me.
I would just like to, I'll just pick up the last piece of that and say that this is such a wonderful area for people who want to be creative, who like challenges, like to be creative, want to solve problems, puzzles. I can't think of a better place to have a career.
I would agree with that. I, as someone who spent a lot of my career on and off looking at long-term care financing and really being concerned about affordability, I do not believe that we can have a sustainable system that's primarily on the financing side through a Medicaid program and with tremendous variation across states. I do think we need a more universal long-term care financing mechanism, whether it becomes federal or whether, we see the evolution of LTSS happening at the state level, and it gets picked up more and more by each state. But I think we need to understand that right now there are a lot of people who are moderate and modest income folks who are just above the Medicaid line. And they are really, really in a really terrible situation in terms of really not having resources for anything. And this cohort of elderly that just passed through was the wealthiest cohort that we have seen in a very long time in the United States. We're going to have a lot more people with financial insecurity, baby boomers and the folks coming behind. So we need to figure this out. And, It's going to have to be a societal question. A number of other countries have tackled this. They're not perfect programs. They have real issues with them. But there is a recognition that long-term services and supports is needed by people, and that it has to be affordable.
Okay.
And not fragmented.
And not fragmented.
Thank you. A great way to end. It is time to bring our session to a close. Barb and Robyn, it has been my pleasure to host you and for our 2020 Littlefield Leadership Lecture. I'm sure that our audience has enjoyed the conversation, so thank you very much. I want to make sure that our audience knows that we have recorded this session, and so that they will get information later in a follow-up email where that they can either access the recording or share it with their family and friends. And if you are interested in learning more about aging science or the Center for Aging Research and Education, please feel free to visit our website. If you would like to explore opportunities to provide financial support for aging science, care, or other school-related initiatives, please feel free to reach out to our development director, Mr. Scott Fletcher. And then before I say goodnight, I would like to thank the members of our School of Nursing faculty and staff for their planning and support for this event this evening. This is an important part of our mission to develop leaders for the profession and society. So thank you again for joining us for our 2020 Littlefield Leadership Lecture. Take care, stay well, and as always, on Wisconsin.